Thank you, the organizers, to giving me this opportunity to discuss youth onset diabetes. Is it a distinct entity? So I will not discuss about in this topic, I will not discuss about the treatment part because my next topic is with treatment. So we'll discuss about first what is youth onset diabetes and how it is different from the adult onset diabetes. We'll discuss that part. So when we are discussing youth onset diabetes, there is no specific age where we can tell that these are below that this is the youth onset diabetes, but if we will go the studies, among the adolescent up to 18 years and young up to 34 years has been taken as youth onset diabetes, and some of the studies has taken also up to 25 years as the youth onset diabetes. So why this topic is so much topic is burning or hot? You will see by 2050 the number of youth onset diabetes in type 1 diabetes will be triple and type 2 diabetes will be almost 4 times what is now in today's date. So this is the projection for type 1 type 2 diabetes. And the overall, if you will see among those youth, the prevalence of youth onset diabetes, you will see the type 2 diabetes is quite significantly increasing. And the importance of this is that there is a very high rate of treatment failure among those patients, and this youth onset diabetes have again higher rate of complications than adult onset diabetes. We know the etiologies: type 1 diabetes, type 2, gestational diabetes, MODY, FCPD, LADA, mitochondrial diabetes, flat-boost diabetes, drug-induced diabetes, and also MRDMA or malnutrition related or malnutrition modulated diabetes. These are some of the etiologies which has been actually proposed for youth onset diabetes. You will see the prevalence. This is the worldwide prevalence among different ethnic groups. Then this is non-Hispanic whites, Hispanics, then African Americans, then American Indians. Clearly shown American Indians has significantly higher number of youth onset diabetes in comparison to the other ethnics. You will see the Indian data. Again, this is the data actually compiled up to 2009. Of course, it's published in 2016, but it has clearly shown that type 1 diabetes has significantly higher number among the Indian youth onset diabetes. It's 63%. After that, it is type 2, it is 25%. But the second phase of recruitment is going on. The one part has been already published, and the second phase is going on. Again, we probably recently again got what is the trend of youth onset diabetes, what are the etiologies, we will definitely get in the recent months. Let us see what is pre-diabetes in youth. Among the US populations, it is 18% among the adolescent and 24% among the young adults. And this prevalence of pre-diabetes among the male, it is much more higher in comparison to the female. And again, you will see non-HDL cholesterol, systolic blood pressure, central obesity, and insulin resistance all have been found to be significantly higher in those groups in comparison to their counterparts. And again, what is clearly shown, if you will see adolescents versus young adults, again, young adults have much more higher number of blood glucose is found to be high. Again, impaired fasting glucose and impaired glucose tolerance is again found to be much more among younger adults in comparison to the adolescent populations. If you see the trends of this youth onset diabetes, the most common form is type 1, as I have already discussed. But as we know, the obesity, overweight is increasing, then probably type 2 diabetes is significantly increasing in this youth onset diabetes. And there is registry, search registry, they have clearly shown that among those youth onset diabetes, type 2 diabetes is found to be significantly higher. And this is our own data, as I have discussed in 2016, this is a published, but the data is compiled up to 2009, has clearly shown that type 1 diabetes is 63.9% and type 2 is only 25%. But this is a recent publication by SK Sahoo et al. Is in 2019, he has clearly shown type 1, type 2 is almost equal now. It is 40%, both type 1 and type 2 is 40%. So again, people see among the youth onset, the type 2 diabetes is significantly increasing among Indian population. So what is this among this youth onset diabetes? If we take type 1 and type 2, what is the basic difference? This is, if you will see the type 1, this is the left side of the panel is the type 1, which has shown that 10 to 14 years and 15 to 19 years as the age where maximum number of actually type 1 diabetes has actually detected. In type 2 diabetes, in the right side panel, there is an increasing trend of disease age you will from overall, from male and female to this increasing trend, but still it is not actually, not it's the full data is in the throughout the India is not available, but that is an increasing trend in particularly in those groups is there. Again, if you will see, this is the source group which has shown what are the cardiovascular risk factors versus type 1 versus type 2. You will see, again, type 2, youth onset type 2 has much more cardiovascular risk in comparison to type 1. If you will see the BMI, of course, BMI is type 2 is high. Albuminuria, again, it is found to be significantly high, statistically significant high in comparison to type 1. Both systolic, diastolic blood pressure, total cholesterol and triglyceride is found to be significantly high. And again, HDL cholesterol is found to be low in youth onset type 2 diabetes patients in comparison to type 1 diabetic patients. Again, this is the complications type 1 versus type 2. You will see this short study from 2006 to 2013. They have clearly shown hypertension, elevated triglyceride, decreased HDL with increased waist circumference is found to be significantly more in type 2 diabetic patients. Again, if you see the complication point of view, both all retinopathy, nephropathy and neuropathy, all are found to be statistically significantly higher range in type 2 diabetic, youth onset type 2 diabetic patients in comparison to type 1. So, youth onset type 2 is actually, when you compare type 1 and type 2, probably type 2 having much more complications early within a few years in comparison to the type 1 patients. And this is same thing has been reinforced by another study, recent study, 2020 study. Again, DKD, hypertension, retinopathy, peripheral neuropathy and arterial stiffness all are found to be significantly higher in youth onset type 2 diabetes in comparison to the type 1 diabetic patients. Let us discuss youth onset type 2 versus adult onset type 2 diabetes, how it is different or similar. In compared to adult onset type 2 diabetic patients, we know that actually this youth onset has been found to be much more severe phenotype. What is severe phenotype? They have greater reduction in insulin sensitivity and higher insulin resistance. Their insulin secretion is found to be high. There is a more rapid decline in the beta cells and overall response to therapy is found to be poor. Again, if you see the treatment failure, this is with metformin alone is found to be within 1 year it is 52%. If you add metformin plus lifestyle, probably it is a little bit less, it is 39%. When this is the older study which metformin plus rosiglitazone, in that study actually it is found to be 47%. The failure rate is 47%. Again, from the trial what they have actually got in type 2, adult type 2 diabetes, if you will see what is the failure rate, metformin failure rate is only 21% per year. And again, the beta cell dysfunction is found to be, or deterioration of the beta cells is found to be hardly 7% per year in comparison to this youth onset type 2 diabetes where it is found to be HIS up to 23 to 25% per year. This is the important part that despite of same BMI and same dysglycemia, this youth onset diabetes or these young people demonstrated 50% less insulin sensitivity in comparison to the adult type 2 diabetic patients. And again, if you see the beta cell response, they produces much more insulin despite of same sensitivity. That means their stress on the beta cell is found to be much more higher. And there occurs, this stress itself leads to deterioration of the beta cell functions. And it has been found to be within 12 months of treatment of insulin or glargine or metformin, there occurs significant deterioration. But in contrast, what we have seen in type 2 diabetes, there might be improvement in the beta cell function does happen with specifically in the type 2 diabetic patients. So this is a study. This is a study which is actually it's not a directly head-to-head comparison of all those studies, but they have taken data from 4 different studies. This is today's study, ADOPT, UK DOD and also UKPDS. What they found that if you see compare youth onset diabetes, because today is for youth onset, all the rest of the 3 years for adult onset diabetes. If you compare metformin failure rate is significantly high in youth onset in comparison to the adult onset. The second part, metformin and rosiglitazone failure, again it is found to be significantly high in comparison to the adult onset diabetes. The fourth one, you see what is the change in beta cell function. That means how rapidly the beta cell is deteriorating. That is significant. The last one you see, there is significant rapid deterioration of the beta cell happen in the youth onset type 2 diabetes in comparison to the adult onset type 2 diabetes. So again, that shows the youth onset diabetes, there occurs rapid deterioration with a rapid failure to drug therapies, and that is the significance of those drugs. So if you see this type 2 youth onset type 2 diabetes, the average age of presentation is roughly 14 years. female have earlier presentation than male. The reason is actually the pubertal changes in the hormones, which makes actually female have an earlier onset of youth onset type 2 diabetes. And below 10 years, usually type 2 diabetes is not found. So that is the significance. And majority time, despite of obese in the childhood, usually type 2 diabetes below 10 years is not found in any of these studies. Again, insulin resistance, which usually classically present in type 2 diabetes, also seen in some of the youth onset type 2 diabetic patients, also type 1 patients. Sometimes we discuss about C-peptide, but it is not always a thing which can distinguish between type 1 and type 2 diabetes, because a newly detected type 2, when there is blood glucose is high, at that time might be have a suppressed C-peptide, and reversely when a type 1 diabetes in honeymoon phase, probably we might get a normal C-peptide. So again, C-peptide has a bit a thing for particularly separating those two in youth onset type 1 and type 2 diabetic patients. How we are going to screen? First thing is that should be either overweight or obesity should be there. On top of that, if there is maternal history of diabetes or GDM is there, if there is family history of type 2 diabetes there are specific ethnic like Native Americans, African Americans, Latinos, all those specific ethnic groups are there, or if there is some sort of insulin resistance are there, we know that acanthosis nigricans, hypertension, dyslipidemia, PCOS, all these are some of the insulin resistance features is there, then these are the group where actually you should discuss about particularly this youth onset diabetes or type 2 diabetic patients. Regarding the diagnostic criteria, it is same as adult onset, because it has been actually extrapolated, that is no specific target is there for this youth onset type 2 diabetic patients. Similar, for impaired it is HbA1c 5.7 to 6.5, and fasting between 100 to 126 and postprandial between 140 to 199 is impaired. And for the diabetic person, fasting more than 126, postprandial more than 200, or HbA1c more than 6.5, or random blood sugar more than 200 with symptoms is normal for adults. Is actually this is the same thing with particularly youth onset diabetes. Let us discuss about the complications. You will see that how rapidly deteriorating, you see in the left side of the panel, how rapidly the HbA1c is deteriorating. Within 3 years, from 75% the HbA1c coming down to HbA1c less than 6% is coming down to 28%. So there is a rapid deterioration in the blood glucose control is there with particularly in this youth onset diabetes. Again, you will see by 15 years, 80% develop some sort of microvascular complication. That is the significance, because by the time 15-20 years one starting diabetes, by 15 years, I'll show them in the next slide, by 15 years, at least by 3 complications, microvascular complications happening. You see, by 1 complication is 6 to 9 years, 2 complications by 10 years, and 3 complications, microvascular complications by 15 years. So again, for those people developing 3-4 microvascular complications by in the middle age, 30-35 years, 40 years, it's a bit difficult and bit actually hazardful thing for those group of patients. Again, you will see different complications. You will see the hypertension. By 10 years, 68% found to be hypertensive. By kidney disease, by 15 years, almost 55% having some sort of kidney involvement. Dyslipidemia, by 13 to 14 years, it is 52%. Again, the nerve involvement is found to be by almost 12 years, it is found to be 34 to 35%. So there is early development of all sort of complications in those group of patients. Again, if you see the survival in comparison to type 1 versus type 2, this is the upper one, the red one is the type 1, and for the the black one is type 2. Again, the survival is found to be significantly less in comparison to the type 1 patient. So youth onset diabetes, type 2 diabetes has actually less survival in comparison to the type 1 diabetic patients. So this is the reason why type 2 diabetes is much more hazardous and lethal than type 1 in particularly youth onset type 2 diabetic patients. Then when we have discussed about type 1 and type 2, but once we are discussing youth onset diabetes, we should focus some of the things about additional other type of diabetes what we get. Classical one is FCPD. Usually presentation is in the first 2 decades. Complications is due to long-standing diabetes. Both micro and macrovascular complications can happen, but the macrovascular complication is less common in comparison to the microvascular complications. Again, pancreatic cancer is one of the things does happen in future in long run. And compared to type 1 diabetes, these FCPD patients are found to have a bit older age, and they are usually found to be lean and thin in comparison to type 1 and type 2 diabetic patients, because we know there is actually exocrine pancreatic insufficiency will be there, so that is the reason these people are found to be lean and thin. Again, coming to the youth onset, the MODY, we know at least 3 successive generations should be there having diabetes with onset of diabetes less than 25 years. MODY 1, 3, 4 responds well to sulfonylurea, and MODY 2 does not require any treatment. So the reason why we are discussing this, because if you are actually typifying what type of diabetes it is, probably because a lot of the time what we discuss, youth onset, start insulin. So probably a lot of the people can be actually kept on OHA, or sometimes they cannot require any treatment. So this is the reason why we should actually, if you can correctly diagnose, that will help those youth onset diabetes for the management of point of view. Again, LADA is another thing. We know that is in between, it is type 1.5 diabetes, age of onset more than 30 years, at least one autoantibody should be positive, and they usually don't require insulin for initial 6 months to 1 year. Subsequently, they might require insulin. So they also represent as a type 1.5 diabetes. Then another important youth onset diabetes is ketosis prone diabetes or flatbush diabetes. That is usually, typically, their characteristics is like type 2 diabetes, but in between they presents like some sort of ketosis, like episodes of ketosis, or that is episodes of absolute insulin deficiency, and during that phase actually they produces ketosis, and they subsequently, once they improves from that point, again their C-peptide improves, again they are actually behaves like a type 2 diabetes. So this is, there is a fluctuating H1C, it is male predominant, and again insulin shows as a, can be as a therapy, insulin can be given, OHA can be given, but insulin is the best therapy for those group of patients. Sometimes during the decay phase, you might get a absolutely negligible C-peptide, but once patient improves, the C-peptide significantly improves in those group of patients. Again, there has been 4 types, that is A positive, B negative ketosis prone, that means there is antibody positive and beta cell is absolutely not functioning. A plus, B plus means antibody positive, but still they have a good beta cell reserve. A minus, B minus means there is no autoantibody, there is beta cell is still not functioning, there is non-autoimmune destruction. And the 4 is A minus, B plus means there is no autoimmunity and beta cell reserve is very good. So there are, usually they have actually classified as 4 different groups for particularly this ketosis prone or flatbush diabetes. Again, this is in nutshell, if you are discussing type 2 diabetes, type 1, then MODY, then ketosis prone and also LADA, then usually mode of inheritance for type 2 is polygenic. Again, type 1, it either HLA based or polygenic, but for MODY it is monogenic, ketosis prone again it is polygenic, and LADA is polygenic. The age of presentation, it is variable, type 2, and so type 1 majority time young, and rest is actually, MODY is also young, but ketosis prone and LADA might have a variable age. Penetrance, again we know that for type 2 it is variable, also ketosis prone, and also for LADA it is also variable, but type 1 there is incomplete penetrance is there. Body habitus, type 2 is found to be obese, rest of the people are typical non-obese or lean and thin. From the ethnic point of view, we know already you have discussed there are certain ethnic groups are prone for this. Beta cell autoantibodies we might get in particularly, we will get in type 1 and also LADA, but usually less in type 2 diabetes or in MODY. And again, first line of therapy, we know different type of therapies there for different type of diabetes. So why you need establishing this diabetes? Because once you are establishing, it is easy for choosing the best treatment. We can anticipate complications, also predict the disease risk in the particular relatives, in their first relatives we can discuss, or we can predict specifically in those group of patients. Again, you will see a diabetes onset less than 30 years. First we have to see how it has onset, sudden onset with severe osmotic symptoms or ketosis. If it is yes, and you go for the antibodies, if antibody is positive, then it is type 1 diabetes. Again, type 1, if it is antibody negative, it is type 1B, and positive is 1A. Then in the opposite side, if you see that there is, if there is no onset is not sudden, there is no much osmotic symptoms, patient is obese, more than BMI more than 30, and signs of insulin resistance, then go for family history. If it is family history is there, it is type 2. If it is no family history, then you can have a mitochondrial inheritance, or it could, then it will be mitochondrial diabetes. If 3 successive generations present, it could be MODY. Again, if there is severe lipodystrophy or lipoatrophy is there, then you can have a lipodystrophic diabetes. Again, for the MODY point of view, if there is stable or mild fasting, it could be MODY 2. If there is progressive hyperglycemia, then it could be MODY 1, 3, 4. If you are having some typical pictures like renal cyst, genitourinary abnormalities or exocrine insufficiency, then we are dealing with MODY 5. If there is optic atrophy or sensorineural hearing loss, then you are discussing with or dealing with Wolfram syndrome. If you have done everything, you are not getting anything, then it is MODY X. So, coming to the last part, youth onset diabetes, is it a separate entity? Yes, absolutely yes. The reason is the prevalence, cause, treatment modalities, response to treatment and complications all are different from the adult onset diabetes. They require specific focus specifically for specific cause and treatment accordingly, and also they need specifically for prevention and management of complications. But still, once we are discussing this youth onset diabetes, there are certain dilemmas. What are dilemmas? How does this insulin resistance and secretion differs between young adults and youth? We also still don't know how they are actually responding or how their beta cell is responding. We don't know. There is also the difference of the glucose insulin physiology requiring a different approach for prevention and treatment. Again, whether from the for pre-diabetes and diabetes point of view, for definition point of view, whether it should be same for a youth and for adult, also we don't know, because whatever now we are using, it has been actually extrapolated the adult definition to the youth onset diabetes. Then again, the implications, if someone is developing transient hyperglycemia, whether they should be followed for a long period or we should then does not require any follow-up, also we don't know. Again, from the renal point of view, we don't know how the renal function is actually behaving, whether this renal hyperfiltration, what does classically happen in young adult onset type 2 diabetes, whether this is does happening or no, we don't know. Again, from the sleep, adolescent sleep disturbances, which is common among the typically among the students, whether it is actually influencing this youth onset diabetes or not, again we don't know. This and then optimal approach to management of comorbidities, like if someone is developing dyslipidemia, higher blood pressure, microalbuminuria, then whether these drugs are applicable to those groups or not, also still that is debatable. Again, the impact of stress and history of trauma has any role, we also don't know, it's still debatable. So coming to the summary, this youth onset diabetes is a burning issue due to rising prevalence and change in the proportion of etiologies. There is a shifting from type 1 to type 2 diabetes, because as we have discussed, type 2 diabetes is significantly increasing. Treatment failure and complications are found to be significantly high in youth onset diabetes in comparison to the adult onset diabetes. Indians are specifically prone for type 2 diabetes due to their visceral obesity. Again, being a tropical country, high suspicion of FCPD should be there among the lean youth onset diabetic patients. Thank you.